Hello and welcome to the Alphagenix Podcast, where we discuss all things men's health and testosterone. I'm Dr. Max, lead clinician at Alphagenix, and today I'm delighted to be joined by Dr. Vanessa Emslie from Willbe Clinic for Women's Health, who are all about hormone balancing. Welcome, Dr. Emslie. How are you?
I'm good, thank you. How are you, Dr. Max?
Very well, thank you. Very well. Thank you very much for joining us. This is certainly an area which intrigues me, but I must confess that when it comes to hormonal treatments, for example, I'm much more well versed in the scope of men's health rather than the female side of things. But tell me about how you got into working with Willbe Clinic and the little background story, if you don't mind there.
Yeah, sure. So I'm 48 years old. I have been studying science and nutrition and health for many years, and I think for me my biggest challenge came about when I was 45 and I went into what is considered quite an early menopause, and I tried hormone replacement therapy. It didn't work for me. I went off. Complete disaster for me personally, and eventually I had to kind of join the dots. Why wasn't the standard treatment working? Why wasn't it working? What were the issues? And my mom has osteoporosis. So from a health point of view and bone health longevity focus, I felt it was really important for me to get the benefits of hormone replacement therapy, but without the negative side effects. And along the way, testing, self-testing, I figured it out myself. I have a lot of genetic variants, which also then impact, also why I went into perimenopause quite early, as well as in how I respond to hormone replacement therapy from a cognitive, mental health point of view, as well as how my body detoxifies estrogen, which is quite important. So along the way, I met Julia, who is the founder of Willbe, and we've just sort of connected. I love science, I love data, I love tests. I love trying to bring multiple points together so that we can give women the best answer that is personalized for them, which is really the fundamentals of personalized nutrition. And with Willbe, it's more about, nutrition, lifestyle, hormones, genetics in one package.
Yeah. So you're melding all of that information into hopefully creating the best possible plan for the individual. Yeah.
Absolutely. And I think that's where we try and create something that is bespoke, but also I think with the challenge that we want women to have the best possible outcome from their perimenopause journey, whether they choose or don't choose hormone replacement therapy. We want to make sure that they have, whatever they do, it's at the lowest possible dose for the best possible outcome. And that means that it needs to be personalized and also adapt as women go through perimenopause, because where you start in perimenopause and where you end up are two different points. So just helping women ensure, obviously, reduced chronic risk of disease.
Yeah, absolutely. I mean, there's a big crossover here with what we do at Alphagenix with the treatment or planning surrounding low testosterone in men. For our listeners as well, if we do have a male tilt, it might be useful for them to know how might you pick up in your partner whether there is a sort of degree of perimenopausal symptoms going on? Because I think sadly we still have a misconception of hormones in society in terms of the symptoms that it can cause if they are sort of not behaving appropriately. So how might someone pick up the fact that maybe they are approaching the perimenopause, and is there an average age that women tend to start exhibiting this?
Yeah. So I think the most challenging thing is that women, the most common thing you hear is that I just don't feel myself again. I just feel off. Something's not right. It's nothing generally in the beginning that can be pinpointed. And also what can be quite challenging is that in the beginning stages, women are still having a regular menstrual cycle, whatever regular means for them, So they're not expecting that some of their cognitive dissonance, some of their inability to find a word, or it just their sleep starts to change. They're not feeling rested. They're tired. They're grumpier. They're more tetchy. They see that their weight is starting to change, and so then they go to the gym more often or start doing, more extreme dieting. And basically, it's like, I don't feel myself, and what I used to do doesn't work. And no matter how many women you speak to, whether it's women in the UK, I'm South African, whether I speak to women in Dubai, it's kind of the same theme, irrespective of culture or background. I don't feel the same, and nothing is working. And that's normally kind of the first clue for us to say, hang on, okay, we need to dive deeper. So it's quite difficult to pinpoint when perimenopause starts. The general consensus is that the average age of perimenopause is around 51, 52, and that's when you have no menstrual cycle at all. But the perimenopause phase can be anything from 5 to 10 years before. So it could be as early as 40, it could be as late as 50 that women start having these symptoms. And the British Menopause Society currently has 44 listed symptoms. Anything from, sexual issues to gynecological UTI, through to skin health, insulin, metabolic syndrome. So there are many touch points, and it's systemic. And I think that's where there's quite a misunderstanding, is that people expect perimenopause and menopause to only affect the ovaries and there's no menstrual cycle. But for women, we have estrogen receptors pretty much everywhere on every cell. And this is why you get things like your eyes start to go. I never used to wear glasses. Brain cognitive function goes. The number of women that come in and will say, I actually went online and I did a test for dementia because your brain fog is so severe because of the lack of estrogen. So so I think those are the two words. I don't feel myself, the phrases, I don't feel myself, and what I used to do doesn't work anymore, are kind of, for me, like the red flags.
Yeah, absolutely. It's so interesting, isn't it, that essentially the hormones can affect each sex very similarly in terms of, you mentioned brain fog, not quite being able to pinpoint what is up. That is such a, brain fog is possibly, I would say, maybe the most common symptom I see when it comes to low testosterone in men. At least some sort of cognitive dysfunction. They're not as quick or as fast in finding their words. It's certainly a symptom that we see a lot of. Okay. Interesting. Yeah, you touched upon the estrogen as well in women having, receptors all over the body. It's not just to do with your sex organs. That's certainly a message that we try and push across to men in the TRT world, because estrogen in men's health has always been, or at least for a long time, was explained as an issue. Estrogen being that's feminizing, that's not good for you. But actually, when you look at the research, there is a necessity for men to have estrogen as well as women for multiple reasons. So you're saying about sort of in the 40s that women might start experiencing perimenopausal symptoms.
Yes. So, and the severity will change. So for some women, they will sail through into menopause, a few issues, and they kind of can't understand why other women are struggling. And are literally, I know in the UK, the statistics are that around 1 in 7 women will actually leave their job in the UK because of their inability to be supported, or that their physical symptoms, whether it's brain function, the inability to do their work as well as they're supposed to the sweats, and those sorts of issues actually become that frustrating that they then choose to remove themselves out of the workforce, which from an economic point of view, self-confidence point of view, is significant.
Yeah, absolutely. Do you think that Why is it that is it genetically driven? The fact that some women have such a not nicer, maybe it's not the right word, but an easier time going through the perimenopause versus a lot of other women who, I was a GP for a good while. A lot of women's lives can be turned upside down from these hormonal changes that occur. Is that genetics? Do we understand why some women are so much more affected than others? Some people have a much smoother journey, whereas others are really kind of almost devastated by these hormonal shifts.
So I think it's a tricky one to say because I don't think there is conclusive evidence. So I'm going to talk from an anecdotal point of view. When women get to the stage where they aren't getting the answers that they need from their GP and kind of the more mainstream options, we are getting women who really have tried. So we generally are finding that we have got some issues with methylation, genetics, as well as detoxification and inflammation. And I'll quickly touch on those, and we can get into them if they're of interest. So methylation, there's two. That's the MTHFR gene as well as the COMT gene. Now, COMT is pretty important because if you have a low COMT variant, you will experience probably an earlier menopause because COMT actually impacts the neuroendocrine aging, which will then trigger when perimenopause starts. COMT also is really important in the methylation process for estrogen, where you're actually kind of splitting estrogen into the very protective metabolite or byproduct. And then you've also got methylation, which is helping to neutralize one of the more harmful ones, which is the genotoxic one, which kind of is where estrogen gets the bad rap. So methylation is really important in ensuring we've got the protective, high levels of the protective estrogen, which is good for cardiovascular disease, for breast cancer reduction, and then kind of just keeping the other metabolite, which is 4H, in check. So that's kind of methylation briefly. There's a lot more to it. Inflammation, when we lose estrogen, perimenopause is considered an inflammatory state. So we lose that protective ability. And so things, alcohol becomes a problem. A woman who used to be able to have 2 glasses of wine at the dinner are suddenly finding that they're completely under the weather. Their tolerance to other factors, they have a lot more swelling. Their recovery time after the gym is harder. And it all links back to, what is their inflammatory profile and how is that then impacting cognitive function? And then lastly, detoxification. So in order to move estrogen through the body after it's been kind of used, there are certain genes in the liver that need to be working well. Otherwise, you're going to send it down into these other estrogen into other pathways. So we do see a lot more people coming in with methylation gene variants than without, but I think that's also symptomatic of kind of where our customers or clients are coming from, when they're kind of reached the end of their kind of capacity in NHS and traditional support.
Yeah, it's incredible, isn't it? The difference. I mean, the modern science you're able to apply and actually kind of highlight. This may well be why you're feeling like this compared to someone else who has a different genetic profile. It's fascinating, isn't it? You mentioned about the inflammation state. I think what people often don't realize is that, a lack of certain hormones can promote inflammation. Obviously, a big driver of, at least it seems to be becoming more apparent over time, is that chronic inflammation is a big driving factor in a lot of chronic disease processes. When it comes to the sort of the perimenopause, and you spoke before about things like osteoporosis risk and your own personal journey, trying to, with your family history, trying to minimize the long-term outcome effects. What are the risks potentially of this hormonal change, particularly if you have symptoms? We talk about it with low testosterone, that men with low testosterone are essentially have an increased risk of multiple conditions now. It's become apparent.
Yeah.
Type 2 diabetes, cardiovascular disease, fatty liver, osteoporosis as well, potentially anemia, depression, even like we mentioned about cognitive dysfunction or brain fog. There's evidence pointing towards that low testosterone may increase your risk of dementia as well. Do you have a similar issue with the hormonal change that women go through? Because what I remember always seeing was that heart disease risk in women is obviously a lot lower than men until post-menopause, and then they almost catch up to men over a period of a few years or post the hormone drop.
Yeah, so that is true. So we see a huge estrogen, I think, they say that estrogen is protective in that time, and that's why men have a steady increase in their cardiovascular disease risk, whereas with women it's pretty steady, but after perimenopause and menopause it skyrockets, and that's because we lose estrogen. So yes, cardiovascular disease, stroke. We also see an increased risk when we lose estrogen. There's a dysbiosis in terms of the relationship with insulin. You see your risks of insulin resistance go up. This is why we get the weight gain, and going to the gym doesn't work because we lose the balancing impact of estrogen. So again, metabolic disease and metabolic syndrome, high blood pressure, increased cholesterol. So that kind of does preclude you. Not that I think that high cholesterol is necessarily bad. It's just, the ratio and the balance of which cholesterol. And we see all of that start to increase. So breast cancer can also increase the risk, which is why when we add estrogen back in through hormone replacement therapy, we do see a reduction in breast cancer risk because it's protective. And then neurocognitive decline, Alzheimer's and dementia as well is also impacted. I don't know the stats offhand. Osteopenia and osteoporosis, again, there is a fine balance between one of the estrogen metabolites, 16-OH. 16-OH is very good for bone health. We know that women who have osteopenia and osteoporosis have less of that metabolite, but also it's a fine balancing act because, again, too much of that can actually be mitogenic and actually increase cancer risk. So this is why just understanding where you are, what your hormone levels are, and the metabolites further down, kind of the food chain, so to speak, are really important so that you can kind of understand maybe you're adding in estrogen, but are you actually getting that bone boosting metabolite? Where can we support the liver who kind of modulates that 16-OH expression, and how can we help?
Yeah, from testing perspective, how do you differentiate that? Is that through things like the Dutch testing? Is that through urinary metabolites of hormones?
Yeah, so you can do either. So but it is in the urinary panel, and that's really because we need to see what's been left over kind of after the metabolic processes. So we use a combination of Dutch. We've also just been doing sampling another urinary test purely because there are differences obviously in the testing. And there is one that we're looking into that has got more of an insight into progesterone. So for people who are really struggling with sleep, progesterone is really important. And depending on if you do or don't make one metabolite thereof, you may find you supplementing with progesterone, and it's not actually giving you that sleep benefit because, again, you're not sending that progesterone down the correct pathway. And then also testosterone. Testosterone is for women too. Women who don't have sufficient testosterone is increased, probably this very similar to men. And we also see loss of muscle mass, loss of libido, sexual desire goes. And ultimately, testosterone is actually converted into estrogen through the aromatase enzyme. So women need testosterone, and sometimes having too much testosterone can also then can negatively impact women. There's more, hair growth, chin, deepening of the voice, and other factors. So again, testosterone is also for women.
Yeah. How does your approach, would you say, just in global sense, differ from mainstream? Because you mentioned there about people coming to you having been through the GP journey and not really either found a solution or got, even yourself, when you tried normal, let's say run-of-the-mill HRT, I don't know how else to explain it, you didn't actually get the best results. How would that approach differ? Because you mentioned about genetic testing potentially there, obviously more in depth. I remember being a GP and looking at HRT and things, and often there wasn't an approach of checking hormone levels that, I think we used to check the gonadotrophin, so the signals from the brain, but it wasn't any more detailed than that regarding HRT. How does your approach on a global sense, obviously you've explained some of it there, but how would you say in basic sense how it differs for the individual?
I think it's very different. And I think I've never really come across any sort of clinic that there are a few, I'm not saying we're the only one, but I think we're kind of in that top 10% in the world where we really try and pull it all together. So what we'll do is we'll look to see what are the genetic variants you have that are then increasing inflammation, impacting the metabolic profile. We see that in the urine. We can map exactly how one metabolite is moving into the next phase. And that gives us insights as well as the genetics. So sometimes, genetics isn't the be all and end all. You may have a gene variant, but is that gene variant actually causing an issue in the body? And that's what we correlate based on the data we get from the urine analysis. And then, genes are generally the ones that we're working with can be influenced through lifestyle and nutrition and nutraceutical supplementation. And then looking to see, how does this all map out? Where are your blocks? What isn't working well? So, for example, progesterone and I have a very tenuous relationship. A lot of people take progesterone at night. If I take progesterone at night, I don't sleep, which I am the complete outlier. And so this is why, it's interesting having walked that myself, because I can really understand why other women are struggling when they're just getting, here's a patch, here's a pill, go put it on and I'll see you in 3 months' time. And it's about trying to then look to see, out of your genetic variants, what do we need to push and pull? How do we do that? Is it, even something as simple as going to the gym, if you don't exercise, that will improve your metabolic rates and reduce some of the harmful metabolites, alcohol reduction. So nutrition, lifestyle. We also look at stress levels as well, because those interrelate. And then we then map out a plan, whether it is with a bioidentical hormone replacement therapy or without. So, for example, there was a lady who is having a very low dose transdermal estrogen. That's the safest way of getting estrogen into the body, very low dose. And when she even has a low dose, we see a huge impact in her levels. So we are not able to use over-the-counter formulations, because for her, it places her at risk because her bad estrogen levels are going up too high. We just need to keep those levels just right. It's like Goldilocks porridge, not too much, not too little, just right. And so that's where the bioidentical compounding does allow us to titre exactly what each woman needs at each stage, so they get the best effect at the lowest, safest dose possible.
Yeah. And you mentioned about lifestyle there as well. What sort of, before we look at the nutrition, what sort of things is it similar to me in terms of weightlifting, cardiovascular, general movement, that sort of thing?
Yes.
The pillars. Yeah.
So muscle, and I think it's the same for men. And even in my PhD paper, the basic fundamentals, if you want to live longer, have muscle. However you get it, keep your muscle. If you don't have muscle, build muscle. So whether that is through weightlifting, that is generally often the best option because it is metabolically healthy, versus cardio. Though sometimes we may have somebody who doesn't exercise at all, in which case I don't care what you do as long as you do. And only then we will start to kind of direct them into strength training. Strength training really is the be-all and end-all. But if somebody is super stressed out, they've got dysregulated HPA axis, so high cortisol, or no circadian rhythm, or over the place, and not following the pattern. Sometimes then actually maybe something like Pilates or yoga would be better, because we need to actually put them into a calm state, low inflammatory. And then once they've got the hormones optimized, then say, okay, right, now go out and start doing something stressful. There's no point going out and doing loads of HIIT classes and strength training if your stress levels are super high. You actually aren't, it's counterproductive for the body overall.
Yeah, so it's looking at their baseline state and working with it. Sometimes it's baby steps, sometimes it's do this first to get you relaxed and more healthy, but then actually add in something a little bit more taxing, a little bit more stressing. Because I think, a good weight session does put a lot of stress through the body in a healthy way. But if your baseline's already high, you're maybe not the first thing to start with.
Well, I mean, at the end of the day, going to the gym is a stressor. In order to get the muscle building response, you need to have stress, but it's a good stress. And it's like the glucose spike. It's a good glucose spike when you go to the gym. It's not a good glucose spike when you've eaten, 2 pieces of chocolate cake. So it's also, again, the context is it needs to be understood in terms of that person's life and where they are and what their ultimate end goal is.
Yeah. And you mentioned, obviously, it's very individualized, but is there any global statements regarding nutrition for most people? Is like, sort of, for me, a lot of it is about looking at whole foods, high protein intakes, particularly if you're resistance training. Is there sort of more general statements for most women that you'll advise, this and this, and then the rest of it might be more individualized?
Yes. So I think for Willbe, our primary recommendation is always a low glycemic, anti-inflammatory, protein-focused diet. So very much anti-inflammatory, because no matter where you are in life, we know that the chronic disease is driven by inflammation. We know that the world is toxic. Women put 127 different chemicals on their skin every day, at least. So pulling down anti-inflammatory whole foods diet is where we start. Low glycemic, generally, because we are finding that when we've got high insulin and sugar spikes consistently through the, more processed foods, I'm not talking about things like sweet potato, then we do see that there is often an increase in weight, which a lot of women find very frustrating and hard to shift when estrogen drops. And then protein focused as well, exactly for that, is to retain and to build muscle and to keep muscle, because it's metabolically active. And ultimately, muscle is actually what is putting the biggest tension on bones and encouraging women's bones to stay healthy alongside the estrogen. If you have got no muscle tension and no muscle in your body, your bones will eventually become more brittle and be more porous and weaken and lead to osteopenia.
Yeah. Where do you sit with your expertise in this area on things like the carnivore diet? Always interested in what people think about it, because it really, I've got a few patients who lean on the carnivore diet for acute phase. I've got a chap who actually uses the carnivore diet acutely when his back flares up, and he says it just completely settles it down within a few days. It's a hot topic, isn't it, the carnivore diet? I'm never quite sure which way to sit on. So I sit on the fence currently.
Okay. Well, what have I eaten today? Okay, I'm a coffee nut, so I've had a latte already today. But I had, so I'm a few hours ahead of you when we're recording. It's already lunchtime. I broke my fast today with a leftover hamburger homemade from mince egg, and I had Kerrygold butter on top. So I am very pro what works for you. Not everybody can digest protein well and easily, in which case they need to be supported, because protein, red meat, has got the B12 and the B9 naturally, which are helpful for methylation. We are very much more focused on a low carb. We are a low carb family, and my son would be a carnivore. He literally complains if he does not have red meat. He's 12. He just wants red meat. So yes, I think as long as you are understanding what is going on in your body, and also diving deeper into the cardiac risk factors, so not just looking at total cholesterol, but looking into things like lipoprotein A, homocysteine, high sensitivity CRP, ApoB and A. If you know those panels and carnivore or kind of keto works for you, I think you're fine. But for some people, it does elevate some of those markers, and in which case, then you do need to be aware of what your body needs and what is good for you. But I think there's also this phase of we've lost seasonality in the world. So if you want, there was recently a study where we're looking at longevity, where they pitched the twins against each other. One was eating a vegan diet and the other one was eating just a normal diet, which was frustrating in itself. But they tracked them for a short period of time, and the twin that was eating a vegan diet saw a decrease in aging markers. But it wasn't a long study. And I think the difference there is that, or the takeout for me personally when I'm asked, is at the end of the day, we should be eating seasonally. We shouldn't be eating the same food this week, next month, and in 6 months' time. But we do, because our food chain has changed so much, and our food supply. But I think in times gone by, we would eat in different seasons. And in those seasons, we would have building, restoring. Just as when we go into winter, we have more hibernation, slowing of the body. We're going for more comfort foods. There is generally a sense of slowing down because our sunlight hours drop. And I think that is where there is a huge disconnect. And we do see the body respond to a very clean, wholesome diet for a short period of time. But I think you've got to do what works for you. So yes, we're carnivore, low carb, keto-ish, up and down, depending how we're feeling.
Yeah, absolutely. I mean, I think what you mentioned there was key as well, which is what I say to my guys who are looking at the carnivore or the keto, is test and don't guess. Because if you go on X diet and then in 3 months' time you see that your lipids, your inflammation markers, your insulin resistance have all improved, well, great. Actually, that seems to be suiting you. But if you find out all of those known risk factors have gone way off the chart, well, then maybe this isn't the one for you. It's about that individualized and actually testing it rather than just thinking, I wonder if this is good for me. But also knowing that subjective markers of how you actually feel on each diet is quite key and interesting as well. What was their normal diet? What was the normal diet comparison to vegan? Was it...
It wasn't a terrible diet, but it was just pretty much your normal standard American diet that they did. So again, seed oils, no seed oils, good quality meat, not, are we eating breads? What is the quality of the food? And I think this is just where the nuances, and from a science point of view, you can't really correlate that well into a healthy diet. And I think also short-term versus long-term. And also coming back to that, for some people, like you said, you've got somebody who goes on to carnivore short-term when his back flares up. So the other thing is that sometimes, when I look at my kids, when they were 6 months old to when they're 6 years old, their diets are very different because their need states are very different. I think also we get set into the fact that when you are 18 or 20, you're eating a certain way. You have the same meals again when you're 30, 40, 50. But the reality is, as we age, why aren't we also then adapting our diet, what's on our plate, based on where our bodies are and what's shifting for us? Why do we think we've got to eat the same as what we did 20 years ago? And I think that's also, we should also have this ability to be flexible and say, you know, this is what's good for me when I'm tired. This is what's good for me when I'm training hard. This is what's good for me, for example, for women who still have a menstrual cycle, but are getting really severe PMS. You know, we know that there are certain dietary shifts that will provide them with better nutrients for that PMS phasing. So why are we going the same food, the same formula, day in, day out, year after year, and expecting it to work? And I think we should be approaching nutrition with a lot more flexibility, and kind of like, if you go out in the summer to the beach, you're going to put on a pair of sandals. If you go out in the snow, you're going to put on snow boots. Our food should be doing the same for us, depending what our need state is.
Yeah, I love that concept as well about the seasonal variation as well, because that would be how we would have lived time before modernization. But also, like you said, your activity levels, your sunlight hours, your habits radically shift depending on where you live in the world. I mean, I live in the northeast of England, so basically the autumn and winter is a bit of a write-off for me. it's you know, it's chilly, it's dark, you don't get a lot of sunlight. Whereas obviously in the summer, you're in a very different place. You go abroad, you get a different level of sunlight, you have a different level of activity. So actually making that conscious, you know, thought about, you know, what my dietary needs might actually change on a month or on a season by season basis as well. That's very interesting. I never really considered that idea. Yeah. So what about in terms of how often do you think when women are coming to you, they're getting their tests done, how often do we go down the route of hormonal treatment versus hormonal and lifestyle, let's say, versus purely lifestyle driven treatment? Do you think, is it common that they need to go the hormonal route as well as the lifestyle changes, or do a lot actually manage quite well just doing through the lifestyle side of the equation?
So I think, as I said before, we are generally supporting women who really are struggling, and who are at kind of the end of their limit. So we do see women who have left work, and we've got women back into work after years, and normally they struggle for about 2 to 3 years before they really start to and where life becomes so traumatic, and you know, they've lost relationship with you know, depending on their husband. Their ability to socialize has been impacted because of their anxiety and cognitive function. They've lost their confidence. So often for us, it is more the case, I would say, that we are recommending hormone replacement therapy because they are coming to us with big need states, which are significantly impacting their quality of life. So we always, though, it's never just hormonal replacement therapy. It is always bioidentical hormone replacement therapy plus lifestyle, mindfulness sometimes, yoga, other things as well to kind of support their sense of well-being. So we do have some clients who, for personal reasons, do not want to go on hormone replacement therapy. And for those women, we do have strategies as well. You know, creatine is amazing, I would assume. And, you know, that in itself, so creatine, about 40% of the body's methylation process, which is very important in healthy estrogen levels. Methylation the body uses 40% of its methylation processes during the day to make creatine. So when we give low dose creatine at about 2.5 grams a day, we see a huge improvement in sleep, in cognitive function, and we can see some of those symptoms improve because we're taking the load off the methylation system. And so we can see better results. So, there's always, and I say that please don't use this as medical advice or anything, caveated, but there are always options outside of hormone replacement therapy that we can recommend. So even with bone issues, osteopenia, osteoporosis, make sure that you know your markers, get your DEXA scan done, know your T-scores. If it's low, let's make sure magnesium is going in, vitamin D levels. Do you have vitamin D receptor gene issues? So that's also something we test. We look at bone health. What is the big picture? How do we optimize bone health? Wearing a heavy weighted vest, walking, high, impact, because that stimulates the bones, muscle, strength training. So, there's always multiple facets for women, but we generally do generally recommend hormone replacement therapy, but it's not a hard and fast rule or an absolute.
Yeah, absolutely. It's a combination approach as such. What about the DA? I look when I was doing my own sort of reading on the website and things. You did mention about it does mention now on DHEAS, which or DHEA. There's a lot of people sort of may be unfamiliar with, because obviously when it comes to hormones, just like in men, it's not just about testosterone. So you're kind of looking at the whole panel rather than just purely looking at sex hormones as such there, aren't you, really? Although it's hard to categorize DHEA, it could be considered to be a sort of adrenal versus, it's a different one. Yeah.
So we do. And I think that's where we look at it slightly differently. So we're looking at the androgen profile, we're looking at the progesterone, we're looking also at the balance of progesterone to estrogen, we're looking at the metabolites, and then we're also looking at DHEA, cortisol, cortisone, melatonin as well, and looking at the pattern. Are you following the normal pattern? Are you having cortisol dysregulation? Why is that happening? Why are you having afternoon slumps? Is it from your diet, or is it because actually, at the end of the day, you don't have enough DHEAS, you're not making enough cortisone? Where's it going wrong? And sometimes it could be 2 or 3 things. I always say to people, there's never one puzzle piece that's missing. It's always 1, 2, or 3 small ones, and together it makes a big impact.
Yeah, and that's a huge difference as well. It's that statement again: if you don't test, you don't know. So you can kind of try and blindly, throw a dart in the dark rather than actually just turning the lights on and actually working out, where am I deficient? What's going on with this? What's going on with this? And work out a sort of holistic plan. How do people get in touch? How do people get to work with Willbe? What's the best system to send them down to get the ball rolling?
So we actually do free discovery calls with myself, one of the team, depending on kind of what's going on. And it's really just heading over to our website, which is mywillbe.com. And there is an option there for a discovery call, or you could reach out to us on Instagram on the DMs. The team are pretty responsive, and they will chat to you and, and see if this is an appropriate route, depending on your symptoms. There's also quite a lot of free resources online that we've brought together. So kind of the top studies in perimenopause. We've got webinars going on. Also, this is Breast Cancer Month. So there's a few things that are happening.
Yeah, excellent. Well, thank you very much for joining us. It's been an absolute pleasure. And I think it's been very useful for our listeners to actually learn a bit more about the female side of hormonal health, and how the work you're doing over with Willbe about being very extensive and actually, like we said before about actually in-depth testing can really give you an answer to what's going wrong, and then give you an avenue of options to help improve how people feel, but also improve your overall health. Absolutely. So thank you very much for joining us.
Oh, it's a pleasure. Thanks for having me, and I hope it's been insightful. I'll just close with one thing. I think the one thing that's quite tricky is that when men are going through kind of like the male andropause, lack of testosterone, it often coincides from a timing point of view when perimenopause starts. And I just wish that there was more clarity and awareness, because I think often, hormones are communicators, and that can then impact how men and women communicate. Marriages, relationships can deteriorate. And it's sad. I find that quite sad, because at the end of the day, I don't think anyone sets out with that intention. And I just wish that if we could get the hormones talking back together, we could get good relationships and happy relationships back. So, yeah.
Absolutely. What you often find is that one side of the equation is getting treated with hormones, and the partner can see that things are changing in them. And then hopefully you hope that inspires the other side of the equation, the partner, to actually consider, is there something that I could be looking at to improve how I'm feeling, improve my mental state, libido, energy, all of these things. Absolutely. Yeah. Well said. Yeah. So thank you very much for joining us. Hope everyone enjoyed listening.
Yes.
Take care.
Bye.
Thank you for listening to the Alphagenix Podcast. Make sure to subscribe to the channel so you don't miss next week's episode. For more resources on Alphagenix and men's health, visit alphagenix.co.uk. Until next time.